Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight we have a great topic session, open mic topic session. Open mic means if you have any questions, you please put them in the chat. We will call on you, ask you to undo your video and chat. We're going to play well in the sandbox as we always do. That's the biggest housekeeping that I have. First, I'm just going to introduce the faculty. Paul, you have more residents on this call that were former residents of yours. I think this is the Paul Lombardi reunion. Okay. Paul, why don't you introduce yourself first?
Sure. I'm Dr. Paul Lombardi. I'm the president of a private practice in Morristown, New Jersey, of 40 providers, and the medical director of the Joint Replacement Institute, which is a two-room freestanding ASC completely dedicated to hip and knee replacement.
All right. What does the 1,000 stand for?
1,000 is the tremendous celebration we had marking the 1,000th joint replacement that we performed at the center.
Wow, that is good.
Very, very proud of it, and I have a great team, and I hope to talk about tonight how we got there because it was just a tremendous achievement.
That's good. You know, we're going to have to go about 17 years at Bronx Care to get there. So, no, I'm just kidding. Okay, Dr. McDonald, can you introduce?
Hello. Yeah, thank you guys very much for having me. John McDonald. I'm in Austin, Texas. I'm a hip, shoulder, and knee arthroscopist and sports medicine physician. I'm the president of our group in Austin. We're about 40 physicians. We are also a division of Ortho Lone Star, and I'm the medical director of that. We're I guess now maybe the third biggest, maybe close to second orthopedic private practice in the country of 180 folks across the state of Texas. So glad to be here.
Excellent, excellent. And Andrew Wickline, would you like to introduce yourself there?
Yeah, I'm just Paul Lombardi's junior resident. Here doing what he tells me to do. He said to show up, and I was late. I'm probably gonna have to come in early for rounds tomorrow.
That's right.
I work in Utica, New York. Been here 23 years, and I transitioned away from the hospital. So we were about 97% outpatient, and when I included the hospital. Now we're 100% outpatient, and we've got out of the last 79 cases, I only had to write 4 opioid prescriptions. So we are now 75 patients without any prescriptions for opioids at all post-op. So that's been our big thing this month. Been pretty cool. Dave Wexler, I saw he was on the line. He also convinced me about this new NAV8 receptor. We'll probably talk about later.
Yeah, we will. We will also. There's a lot of connections here. Paul says he reminds me that when he was a medical student, I was a resident dissecting a cadaver and doing a knee replacement on a cadaver.
Hip replacement. Yeah.
Hip replacement on a cadaver. Yeah, and I hope I didn't cause the cadaver to be a cadaver, but that was good. And Andrew Wickline replaced my hip 4 months ago. I went up to Utica, New York, because you cannot find a good joint replacement surgeon in New York City. So I went up to Utica, so that was good. So we're going to start. There are so many things, so many of us do all the time. And the whole concept of this tonight is to share those things, share what you use, share what technology you use, and hopefully to say what I've talked about on LinkedIn a lot. Are we doing everything to prevent anything bad from happening? Okay, so let's start in the pre-op area. Okay, let's start in the pre-op area, and let's just go right into some pre-op protocols you may use. John, you want to start off on nutrition, maybe, or that's a big topic. Let's just I'll lead off with some topics, and some other people in the audience will take it their own way.
Sure, happy to. Yeah, the nutrition aspect was a real journey for me. Starting in 2022 or 2023, started getting interested in some of the literature that was out there, and then I'm sure you guys are aware. In December of 23, JBJS published a clinical concepts review on perioperative nutrition, and it kind of took my breath away. It was one of those things where you go, man, if we're not doing this, this feels like we're outside the standard of care. And this included my joint replacement and spine partners specifically. A lot of the data surrounding it is pretty robust and comes from general surgery, but there's a lot of orthopedic data associated with it. And essentially, the majority of people when they enter into a perioperative space are at least barely appropriately caught up with their nutrition, and then when they enter the postoperative phase, they're definitely malnourished or undernourished. And then that doesn't even count the folks with diabetes and end stage or renal problems, et cetera, et cetera. And a lot of this we've extrapolated into our sports practice, and I get asked all day, every day about BPC 157 and collagen and peptides and all these things. And how can I heal from my ACL faster or build my quad strength or that sort of thing? So we went down a pathway at Ortho Lone Star and started looking for partners in this process. And there's a few folks around that handle this, but we found a company in Mend that was already out there doing what we wanted to do, and so we started across the state with mostly joint replacement, and have incorporated that with education before surgery, preoperative optimization. This includes branched chain amino acids that are very specifically data driven, based on NIH grant funded studies. And we tee these folks up, and then perioperatively specific timing for carb drinks in the 24 hours before surgery. This is a little different than drinking a Gatorade beforehand, things like that some surgery centers do around town that we've come across. And then postoperatively, especially in our ACL reconstruction world, one of the hardest reasons or most challenging things is building quad strength afterwards. So we get those patients doing this, and it feels good because it's something that is is good for your patients. That they ask about, and they have an interest in. There's a lot of data that shows that people are interested in these types of things, and it's relatively inexpensive. I mean, I spend I tell them to buy a $200 or $180 Polar Care that they could use a frozen bag of peas for, and I tell them that too. And people want Polar Care or Game Ready or whatever, and I'd rather than spend the $180 on perioperative nutrition. And so we've gone and across the state, we collect our data on every joint replacement for the last several years now through CareSense, and we're starting to look at the patients that use this and the patients that don't. And some of that data, early data, is very good, biased towards the perioperative nutrition aspect. And so that's been a real change for us. The hard part is communication to the patients, because as you can see, I'm long-winded. I'm already taking up most of the hour talking about this.
No problem.
No. But the problem is getting somebody who needs it but may not be asking the question about it to go ahead and use it, and why is it important. So we've spent a fair amount of time creating videos, QR codes, handouts in clinic, that kind of thing, to try to get people, hey, while they're waiting on their doctor or their PA to come in, go ahead and watch this 10-minute video on why we think this is important. And we're starting to see some changes in that hopefully will improve some outcomes and get people to buy into it.
Andy?
I just have two comments. So that was really a great summary, but I would agree. I think it's bordering on negligence at this point if you're not doing this for your patients. The data is very clear that 2 years after your surgery, compared to those patients who got placebo out of that initial Chit Ranawat paper, the award-winning paper, those patients had persistent strength gains at 2 years compared to those who did not have it. Two of the key indicators for independent living, all of these patients are elderly patients, want to stay living independently, and of course stay out of nursing home, keep costs down, grip strength and quad strength. And so if you've got a 20% improvement in quad strength just because you gave them some essential amino acids around the time of surgery, that's a no-brainer, and actually I think has to be done. The second thing is, I've done lots of education of the books and all that stuff.
Yeah.
Sometimes you just have to tell them a quick story. And the essential amino acids, they upregulate the M2 macrophages, which are the garbage men of the leg. So, I'm here in Syracuse where the state fair is, and everybody around, all my patients have been to the state fair, and it's always dirty and disgusting. And in the day, there's always trash everywhere. So I asked the patient, I said, "Have you ever been to the state fair?" "Yeah, I've been there." Is it dirty at night?" "Yes, it is." "So do they hire one garbage man or they hire hundreds, and they call them a couple weeks ahead of time and get them ready to be there to be able to clean that up so it's ready the next day?" Well, that's what this medicine does. This is medicine that you're taking, this essential amino acid, and you're recruiting lots of M2 macrophages, garbage men, to clean up the damage I'm about to do. And it's going to slowly improve your swelling, get you recovered faster, lower your infection risk. And so I think when you give patients a real story that they can see, okay, yeah, maybe it doesn't taste great for some patients and so forth, then they say, okay, this makes sense. I can actually get it down. So I think sometimes we give too much. It's kind of like the pharmaceuticals. They give like 16 pages of information. The patient just wants 3 or 4 sentences.
Yep. Paul, what's your feeling about this? And then I also want you to spin off on how you educate your patients and what apps you
Sure.
use, maybe. And
So my comment in the chat here was this is the final frontier, and I think that Andrew is 100% correct. I mean, I think that it's negligent if we're not first recognizing that this is an issue. And I must say that I was negligent with this because we're
Mhm.
so focused on so many different things. This was something that got past lives, and me included. And I thought I was being a hero by just looking at albumin. Albumin levels. Okay, albumin levels below a certain number, I need to be concerned about the nutritional status. But that's completely untrue. And I think I'm in the process now with my group and actually my hospital, Morristown Medical Center, of instituting this program across the board because it's absolutely, I think, essential for the success of patients. And I totally agree with John and Andrew's comments on this.
let's
Can I make one more comment real fast, Ira?
absolutely, John, go, go.
The other thing, a couple of my partners pushed back on this when we initially started it and said, okay, well, what about, having someone with a little bit of creatinine bump or things like that, and they worry about the protein load in somebody who might have a little renal insufficiency. And so we ran it by several of our nephrologists in town, and everybody resoundingly said, no, 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 no. We would way rather have them be optimized nutritionally with a little bump transiently in their creatinine from a protein load than go into the surgery malnourished, essentially. Like that data has swung dramatically in the nephrology world too. They don't worry about the protein dumping and the load there and all that kind of stuff anymore. They're much more interested in their world on nutrition optimization around the time of stressors.
Yeah, so it's a great thing. How about educating patients?
Mhm.
It's people don't like to do it. Paul, talk to me about how you educate your patients and the apps you may use and things.
So, for educating my patients, I have an excellent nurse practitioner who has everything organized very nicely. One of the apps I use is My Mobility, which is a Zimmer product.
Yeah.
And I
Okay.
just want to state for the record, I am not a consultant for Zimmer. I don't consult. Actually, I have no consulting agreements at any company, but particularly with Zimmer. And for the pre-op education you can actually tailor the My Mobility to what you would like to have for each patient, right? For the patient's hip and knee replacement. Different videos, different PDF preparations that you could do for patients. But something I started not that long ago was now I think these PCM visits are very crucial now. Medicare is allowing us to charge for these. So I'm using these PCM visits really now for my nurse practitioner has really an hour to sit with these patients and go over every aspect of their care from now their nutritional status, to start to have this discussion and everything down the line. And I think the PCM visits have really allowed our group to center education significantly in that one visit.
Yeah. Value education, John, for you, anything special in the sports arena?
Not technology wise, post-operatively from a communication perspective, I know we'll get there, but we do some stuff. But pre-operatively, it's pretty nuts and bolts. We may not get paid for a pre-op visit. I still think it's super important in our world, and I bring them in and I talk to them about expectations and post-operative rehab course and what we may or may not find. I really think the face-to-face time spent with those people pays dividends down the road.
Andrew, comments? I know you've written a couple of books on this.
Yeah, I've got over 8,000 books now to my personal patients, and it's we just did a ViewMedi. It's a 3-hour ViewMedi that should come out this weekend, going over all the top 10 March to a Million low opioid surgeons. I invited them to speak to do this kind of consensus conference, and they all said the number one thing to help get down to low opioids was education. So I think if you're not doing it, I think you're missing the boat. But you've got to get the patient engaged. The rest of your staff has to be engaged. You can't, if you just throw something at the patient and then never reference it again, it's not going to be successful. I think that's why the large group uh, um, education classes really weren't that great because it was watered down because there's 10 surgeons and they each do something different. So having a specific protocol that all of your staff knows are all on the same page and your therapy team knows is the key.
So Andrew, how do you deliver that to your patients? Do you do a PCM visit? They do it virtually? How do they engage the information?
So every patient, when they sign up for surgery, gets my book. You can see this patient really loved it. It's got a million stickers on it. And and then they're told that to bring it to every appointment, and they're told they need to read it, and that I'm going to be asking them questions. They know that at the 2-week visit, I'm going to give them a grade. So they're all worried. No one wants to have a C from Dr. Wickline. It really does help that you get them engaged. And then once they start reading a couple of those and seeing a couple of the videos that go along with it, then it's an interesting. It's so thick now, this book, though, it's kind of daunting. So that's why you need to have some videos to kind of get them saying, "Oh, you want to learn more? Go look at these 2 pages." But frequently, by giving this book, I see them at the pre-op visit and they've lost 12 pounds because they saw the BMI calculator, they saw what their risk was, and I gave them 2 pages on diet. You have no idea how many patients will tell you they had no idea what a healthy diet was. They really thought that Doritos were healthy. I think it's crazy.
They're not healthy.
See,
Yeah, yeah.
Doritos
Even the
are
nacho
healthy,
cheese?
Utica.
the Raging Cajun ones that might be healthy. I don't.
The Cajun ones, yeah. So let's flip. So because we're a third of the way through, so we're going to go into the operating room. All right. Let's look at some technologies. Paul, you had said right beforehand about your ASC and its incredible efficiency. All right.
Yes.
What technologies you use to make it that way, or do you just yell at everybody to go faster?
No, I'm a lover, not a fighter.
Right.
So when I purchased this ASC, it was an existing ASC. I did not build it, 2 rooms, and it had a two tray sterilizer. And when you do your pro forma, we did our pro forma where we were going to perform 35 cases a week. 35 cases a week times 5. So we needed to be able to process roughly 175 to 190 trays a week. I had a capacity of doing 12 trays a day with the existing technology that I had. So what I was able to do was once I was able to get licensure, and I could do out-of-network cases basically just to keep the lights on. With my existing technology, I actually employed Steris to outsource my sterilization, the difference of the trays that I could not process. Very expensive. It was $110 per tray. Right. I was spending close to $16,000 or $17,000 a month just to outsource my sterilization, just to get the operation off the ground. And obviously that was not sustainable. Then I looked into the pod technologies, and Rob Turbett and his company came and showed us this amazing technology where now I basically can put all of my trays for a case into one pod, wheel it into the sterilizer. It comes out of the sterilizer, ready to go, gets wheeled into the operating room. The scrub tech takes the trays off and is able to put it onto the back table. So there's a tremendous amount of efficiency that we're able to obtain. Just from being able to process these trays, I went from $17,000 a month to Steris down to zero. I was also employing agency sterilization techs to be able to sterilize into the night with my two tray sterilizer. I no longer use agency techs. So that was one area where we're able to obtain significant savings. Second, from an infection standpoint, so now with these pod technology, there's no wrapping, there's no blue wraps anymore. And how many of us have been frustrated with holes in the wraps, right? All day long, holes in the trays. My paranoia wasn't the holes that I was seeing, but the holes I wasn't seeing and the holes that we're not able to detect. And was that a significant source of infection? So the pods were able to, I think pods are a cleaner technology from an infection standpoint. You don't have one case being handled, wrapped, you have 6 trays, now a person has to wrap each tray individually. Another source of potential infection. So the pod technology of us was a tremendous boon. The staff loves it. And I think I sent you a video. Would you be able to cue that up?
Yeah, I'll cue that up right now. Hold on. Let me just get to this. All right. Oh, this is the Mend. This is the Mend website. They got a nice looking website. I gotta find out who developed the website, It looks pretty good. I am going to go to the Instagram. Here it is. This is the one, right?
Yep.
All right, we're going to play that. This is one of the pods, and
So this has been wheeled into the operating room. Circulator opens it up. The indicator is actually on the front gate. So this is actually the amount of time it takes to set up a case. It's right here, right?
yeah, so there's no holding the blue wrap and holding it
That's
while
correct.
the nurse looks for the holes.
And the nurse can go out and get the next patient while the tech is setting up. So that's another 6 to 8 minutes.
Right. Yeah, you eliminate some staffing. It saved us 20 minutes of turnover time. So
Yeah,
with a similar product. Yeah.
yeah.
Okay, so I think that's cycling again, but
Oh, it's cycling. Yeah, yeah. Sorry about that, everybody.
so now on top of the pod technologies, we also installed a reverse osmosis water treatment facility in our practice. So that's really the state of the art now with sterilization technology. So yeah, we feel very confident that with the pod technology combined with the reverse osmosis water treatment, that we're going to significantly reduce potential infections.
John, in your or how do you get efficiency for wheels into incision and turnover time? What any technologies or any tips you can have? Because Charlie DeCook always talks about wheels into incision being the holy grail.
Yeah, I think people make a huge difference here in training. It is, and for us, it's less so technology, frankly. I mean, we made the joke a little bit ago before when people were joining that, we actually have paper charts in our surgery center. Still, it's the only place I know in town that still does it, and it's unbelievably efficient, actually. But for
Well,
us,
that's technology. That's technology.
yeah, it's right. For us. Yeah. For us, the anesthesiologists that come into our surgery center are handpicked. They're all incredibly well trained from a regional perspective. So there's not this poke and poke and poke. We also don't have any residents or fellows from an anesthesia perspective. We do orthopedic wise, but not anesthesia in our surgery center. And so I think that these guys are very adept at getting the patients in at the appropriate time, getting them blocked, even if we're flipping rooms. That aspect is taken care of. So that's really nice from a sports, even joints perspective. And then I was always taught in my fellowship, like, okay, 7 minutes on a knee and maybe 12 minutes on a shoulder from the time you're in to the time you're ready to cut skin. And we try to, that's a pretty fast time to get to, but we effort for that every time. I think the physician involvement or surgeon involvement specifically in patient positioning, I've always felt is super important. You're the one when you're there is one, I think there's complications that don't occur when you're the one eyeballing everything. And then two, I think that everybody has a little skip in their step when the surgeon is there, when they're still in the break room drinking some coffee, people aren't so motivated to keep going.
I think a hint.
Big key and measuring it, letting them know your measuring time is a big piece. So are you looking at it? Gets pretty competitive in there.
Right, Lacey. All right,
That's a great point.
Yep, Paul.
Yeah, I think a efficiency, a hidden cloak of efficiency is staff, and not having turnover of staff in your ASC. When we opened our ASC, I handpicked most of the staff, people I've worked with for 15 or 20 years. The type of staff where, including the anesthesia providers, basically, and we all know this, that you could walk into your case, we don't have to talk to one another. we could go the whole day without talking because we understand each other's movements, the tone of voices, what needs to be in my hand next. We buy them lunch every day. We treat them with respect because it's very clearly shown that staff turnover is very expensive to train these people, but also they have to sort of get in tune with the way you do things. And if you're constantly having turnover, that is a tremendous waste of efficiency.
Yep. Andrew, what's going on in your ASC to make it so efficient?
So we also use one tray, cube, so to speak, the Rob's equipment. And it's really made a difference for us. It's the same every time. And again, the nurse can go out and pick the patient up with the anesthesia provider while the tech is finishing. Um, I use Medacta has some single-use boxes, so we will open those pieces up as we size, and they're sterile every time, and they're cost neutral compared to the Stericubes. There is some trash, of course, with that, but I really like there's much less heat and the metal ion generated by cutting through a plastic jig versus a metal jig. So particularly for those surgeons that are using press fit, that might make a difference. Of course, that high heat leads to it's a burn that we don't really see, but that leads to swelling and can be problematic. Intraoperatively, I really like the matrix metalloproteinase products, the XBio stuff from Next Science. I still can't believe that it makes such a huge difference, but it really helps reduce swelling while killing bacteria. I use the Inkwell product that we put the tattoo on at the end of the case so patients can measure their own swelling and range of motion. That again, it gamifies it. They know at the bottom of every page in my book, it tells them what their number needs to be. And so now we routinely see 114, 120, 130 degrees at 2 weeks post-op, without a therapist and without opioids. So that part has been helpful. And then lastly, something else that might be of some benefit to those on the call. I use ProMap. It's a simple iPad. It's this size, and they can make templates for you. So my rep is able to, as I call things out during the case, my rep is able to touch different boxes. And so then when the case is done, I go where I review all the boxes, subvastus, what antibacterial wash I use, what closer I use, so forth. And it automatically makes an operative note. And it's immediately emailed to both my office and to the front desk, so it can be billed the same day, and it's a great data collection tool.
Wow. There's a lot of technology, in one thing. Now, let's go back a little bit to a couple of things you touched on. I'm gonna go back to the irrigants, and then I'm also gonna go back to the Inkwell technology, which was Jimmy Chow was very involved in that, and we have in my experience coming up about that. Paul, John, you use any special irrigants or stuff like that? We use in our hospital. We trialed 3 different ones, and they actually chose the experience one that the surgeons did, independent from me. So we're using that for biofilm and for irrigation. Let's start with John. You're doing a lot of scopes, so it's not the same.
Yeah, I've talked to, actually in preparation for this, just because I knew this was going to be a topic. I talked to some of my joints partners around the state, and there's some biofilm disruptor, Bactrisure, that kind of thing. On occasion for infected joints, for definitely, it's pretty cool. We're partnering with a company that has an antibody that disrupts. Biofilm that is in FDA trials right now. We're a site for it. That's going to be a lot of fun. I think there's a fair amount of data already that will be a game changer for single stage joint revision. These kind of biologic stuff will be real important down the road. But routinely, nobody was using anything aside from an occasional antibiotic irrigant, and nothing fancier than that.
Yep. Paul, your feelings about this?
So, obviously I'm one of the older surgeons probably in this call. So I was using nothing for a lot of years. Then one of my young partners came, who was using diluted betadine, and and said, how come you're not using diluted betadine? And we wound up actually doing a study with NYU. There was an arm of vancomycin powder intra-op, diluted betadine, and then nothing. And actually, there was really no difference in infection rates with the different solutions. So for routine cases, we're actually have gone to not using anything unless there is a particular piece of a case that someone's individual case that would require irrigant. But we've gone to no special irrigants for routine cases.
Interesting. I'm good friends with Joe Zuckerman, so I'd like to say if your infection rate's 100%, of course it doesn't change, right, Paul? Anything? Just kidding. So I'm gonna share my screen to this Inkwell thing. I'm gonna have Andrew tell us what it is. This is fascinating technology. So could you see this coming in? You see my screen?
Yep.
Andrew, what's going on here? What is this? Is this
So it's a temporary tattoo. It lasts around 9 days. You place it on once the skin is dry. It does three things. As the skin expands with swelling, the distance between the dots gets larger, so it measures volumetric change and swelling. The fiducials, those crosses, are there to help estimate range of motion, and then the ink itself is a color. It's a temperature sensitive ink, so don't really know what to do with that data, and I don't think anyone has any great information on that. I mean, really, I think the FLIR imaging is one of the next tools I'm looking at to try to look at the inflammatory response from the damage we inflict on these people. But the tattoo itself, you just hold your iPhone up to it, and it automatically captures, has an algorithm, automatically captures the range of motion, and it tells the patient if they're on track or not. And then again, it has the dashboard and so forth. But I think the real key is that they've got the cost down such that you can actually make a little money. So, um, you know, it's about $180 to $225, depending on the market, after you pay for the tattoo, the app, and the education book. So it's still a net positive, and now you've got a therapist looking at the patient remotely. So that's how they're getting paid, is the remote therapeutic monitoring codes. You need 16 codes within the 30 calendar days to qualify.
Yeah. So I just thought this was cool. I interviewed and I'm friends with Jimmy Chow, and he talked about it being sort of like facial recognition software. And I think that's kind of an interesting technology, sort of a low cost, interesting technology that's certainly
And,
coming
and
down.
one thing,
Yeah, go ahead, sorry. Yeah.
one thing I want to point out is that, I tried Motion Sense. We've done On Track, Track Patch, and they all have different, varying success, pros and cons. Certainly with Motion Sense, which I think got shelved by Stryker now, boy, the calibration was painful, and then of course you got to charge the batteries, and the sticky created a problem for the patients. And the app download, you could spend 25 minutes with the patient in the room with your MA, spending all the time. You can't do that in private practice. So I will say that the Inkwell team has been pretty good. The patients actually, I'm shocked at how maybe COVID changed the way the patients are, but they're able to download it now, no problem. And I don't get any pushback. So,
Yeah.
so to actually make a little money and have no pushback was an unexpected finding for me.
So, Ira, can I put my managing partner's hat on for a second?
Yeah, absolutely.
So, I'm the partner that always says no, right? Because I'm the managing partner, the medical director of my ASC, and my frustration currently is who's paying for the technology? Now, the technology is great, right? So obviously Medicare is not paying for the technology. Well, neither are the commercial payers. There's this myth of, it's a pass through, they pay invoice, but they really don't. They parse out the prosthesis and everything else you're paying for. So any advanced imaging platforms, robotics, any types of special wound applications. So I'm just curious, experience on the panel and in the audience, now obviously the technology is all very good. is it good enough where you want to take it off of your margin in your ASC?
Yeah, I actually feel very similar to you. We looked at in a current trial with an insole company that does the exact same thing, that measures range of motion and steps, and has pretty interesting technology as well. But again,
Your home,
who's going to pay for it? Who is going to what are we going to do with that data? It has to be actionable for the patient to see the value in it, and not just monitoring. And so I think hopefully you get to a point where you say, "Gosh, we've done 1,000 of these, like you guys have at your facility there," and we say that, okay, if you are not at this point, or if we see this amount of swelling, or if we see this temperature change, this puts you at risk. This is what we're going to do to intervene, or we need to come see you more often, or you need to do this instead. But I don't think we have anywhere close to the data for that at this stage. The hard part is it's got to be funded by somebody in order to get that data.
I'd like to make a comment on that, Paul. It's a great point. If you're the managing partner, you're the chairman, you're somebody who is responsible. You always have to look at where the ROI numbers are. CMS is coming out with now the CMS team model. So and we did a study at our hospital that our reoperations, 57% were manipulations under anesthesia. So if I could find some technology, well, these are no 50, not 50% of the knees were 50% of 7% of the ones who went to the OR were manipulations under anesthesia, and that certainly adds to your to the penalty. If I could find a technology that isolates these patients earlier, whether it's a My Mobility app, or whether it's the Canary Knee, or whether it's the Inkwell or something of that nature, or with Andrew's case, using the experience to decrease the product experience, decrease swelling and get the range of motion early, then I could avoid that reoperation, which is going to go right against my CMS payments. So I think things may change over time if we can find the right return on investment. But I agree with you, John, 100%. If you're just throwing toys at something, it's not gonna solve anything particularly. I was gonna drop back for a second because we talked about time in the OR, and Lacey brought up a good point about, are we measuring time? Now, Charlie DeCook has a great video of him measuring time. He uses a product called Ospitec. They're not I don't have any relationship with them either. But they do time management in the OR, where everybody knows what Charlie talks about, his massive time transparency. So have you guys thought of putting something like that time tracking kind of software in your ORs, or you doing fine without it?
So if you haven't done so, anybody in this panel or in the audience, you really got to go down and visit Charlie DeCook's operating room, because we were there. I took my team down there, and it's just a sight to behold from an efficiency standpoint. And I have to admit, I'm just not that ambitious to be able to do 12 by 12. I'm pushing 60. That's not my ideal. However, what Charlie DeCook has done with that is it really demonstrates where the holes in time are in your operating room. He has it down where, okay, the patient hits the room here, your incision is being done here, your cup is in here, your stem is in here, and he actually logs that time data over the course of a month, and all the partners sit down and determine who's. But I think it's an excellent exercise to determine where your holes are in the time management of your ASC.
Exactly. And that's what we deal with, because everybody says, I don't want to do 12 by 12, and the answer is, do you want to do 5 by 10? Whatever you want to do, we want to make you more efficient for your day. You can go do, he plays pickleball, other people play golf, some people go and meet their wife for lunch, but go ahead and make your day just more efficient. We're not trying to rush you, but there's a lot of pieces around the actual OR time that we can help with, which is set up and let you, go and do your work. It 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 if you don't measure it, you can't change it. That's our philosophy as a management company, saying you got to know what you're doing and then make improvements.
All right. This was the original article in JOEI of all places. Who would know? 25,000 views on this. Still number one. Try the Cook's 12 by 12, obtaining true OR efficiency. I really recommend people read this great article. We don't get paid if you read it. It's just an amazingly written article. Yeah. So let's talk about some post-op time. Okay. What do you do? What do you do in the post-op period to track these patients, to monitor the patients? John, anything special?
I'm a big believer in physical therapy and exercises in our sports world, and I think it makes a big difference. I think involvement with one-on-one with another provider of some sort helps improve patient outcomes. I think left to their own devices, a lot of folks, especially minors, won't engage. Our we get our ACLs in post-op day 2 and our hip scopes in post-op day 1. But what we've moved to is using a company called Limber Health for our post-operative PT. They get assigned to their therapist. They come in, but we've been able to limit the number of inpatient or in-person visits, but still get engagement. Physical therapists can communicate with them. We've been successful with that. They moved it over to our joints partners, and across the state, several of our groups are using it now, and that's been a real helpful way to engage. Just those visits between 2 weeks and 6 weeks and 3 months and 6 months when they're seeing their orthopedic surgeon. I think when patients are, as Dr. Wickline mentioned earlier, when patients are engaged, the outcome is always better.
Do you make money off of Limber? Is there some positive return to the practice?
Yeah, I don't have any consulting arrangement with him or any of that kind of stuff. Neither does our group. But we have to balance. It's actually like, man, you're taking away physical therapy visits that would actually make money for the group, and then giving it out. But what we found is that sometimes that allows for more new patient visits to come in who are being managed non-operatively, that sort of thing. And so the therapist have become taking the patient visits that maybe can be done at home and filled them in where some of those visits have more modalities done or that kind of thing. So it makes the visits that they backfill in potentially more profitable for the patient.
So this is the company, right? Rehabilitation therapy.
That's correct.
Yeah. Very, very interesting.
So I have my therapist sees the patients for knees an hour pre-op, similar to Paul, but an hour of education, physical therapy pays quite well, way better than the 15-minute slots that they get, for post-op. And then she sees every patient for a new patient visit after surgery one time at week 3. But then the rest of the time we use that Inkwell product, and again we were able to see some proceeds from that. So my therapist is still whole, or about 95% whole. She's not perfectly whole, but she loves her job. She doesn't make people cry anymore. And then separately, we're still able to bring some money back into the practice. So far it's been working pretty well. But again, I have a conflict with them because I do swelling stuff, and so I'm doing some research with them.
Well, I'd like to kind of pivot this to a combination of everything related to pain for the rest of tonight. Any technologies, intra-op for pain, new drugs post-op for pain, uh, cocktails, various cocktails. I remember Brian Fuller on LinkedIn who said when he first went to practice, he asked the questions, does anyone have the perfect cocktail? And I just posted my recipe for my Manhattan. And it got like 65,000 views. And I guess maybe if they drink enough Manhattans, they have no pain after surgery. I don't know. Paul, what do you do? What technologies you use for pain? You do joints.
So for technology, I'm really pretty much doing our pain cocktail. And obviously there's a lot of give and take, whether or not to have, Toradol, dexamethasone, clonidine. There's just so many different combinations. So, in our ASC, we wanted to standardize it, so we came to consensus over the type of cocktail that we're using intraoperatively for pain management. We're debating now whether or not to do the adductor canal blocks preoperatively or postoperatively, because there's some data to suggest that you actually get some benefit by doing it post-op rather than pre-op. But I would say we're pretty standard in our postoperative pain protocol, and actually I've invited Dr. Wickline to New Jersey to give me his spiel on trying to get opioid free, because I'm pretty close. And the one problem having to get in trying to go completely opioid free is the patient's buying in. Because if you tell a patient you're not going to get an opioid prescription, right, you get pushback from them because they feel like they're exposed. So I was interested to hear from Andrew. How are you able to get the patients to buy into no opioids?
So admittedly, I've been doing since 2016, 17, 10 pills or less, and then for the last 5 years, 10 tramadol or less, and many patients completely opioid free. So I've had a lot of success with that. So, the book is called Less Swelling, Less Pain. The book talks about it, from 6 weeks pre-op and again, once you build it, they will come, right? So it's everyone just knows that if you follow the book, you follow the protocol, it's all going to be fine. So admittedly, it's a leap of faith. So maybe you just start with a lower number, and there's so many studies that say that many patients do well with just starting with a lower number, and they don't end up with refills. But first of all, just 10 pills leads to a 6% risk of addiction. And for every 1,000 scripts you write, you're personally responsible for 17 overdoses within that patient's household. I've done over 20,000 surgeries. That means 340 overdoses are on my ledger. So I use Iovera. I offer Iovera to every patient. We have about an 85, 86% take rate on that. There's some patients it's not covered, so they pay cash price for that. One thing that I'm going to start doing, we used to use steroid dexamethasone 6 to 12 milligrams, kind of maximum, but there's several studies saying 20 milligrams, and then one study out of 2022 that says 1 mg per kg for the high pain responders. I'm hesitant to do that, but that's the study. It's out there, so we should be talking about that. And then for the last 79 patients, we have offered Journavx. And out of those 79 patients, only 5 total patients got an opioid prescription. One was from an outside. We looked at everybody through iStop. So only one person got it from outside of my office. The other 4 did need rescue meds. So it means 74 out of 79 patients completely did not even get an opioid prescription. And so I anticipate that by the end of the year, I'm going to be around 97% completely opioid free. I won't even write an opioid prescription as a baseline. The Journavx, the key is you want to start at pre-op, and you need to work with your rep. You call your rep, and I can, anybody on the call, you can reach out to me. I can connect you with the senior, the lead on this. But basically, you just tell your rep, listen, you make your money from how many prescriptions are filled. I'm not going to make any money from this, so I can't have any headache. So if you want to hit that President's Club bonus, I need you at the end of every day. I'm going to call you. My medical assistant is going to call you and say, here are the 5 pharmacies Dr. Wickline sent a prescription to. And you're going to call that pharmacy and make sure that the wheels are greased so that this $30 coupon is applied appropriately. And so once that gets in place after about 3 or 4 weeks, most of the pharmacists know how to do this, and it now becomes second nature. But then you don't get any phone calls about it. So that's number one. Number two, it has an onset of action at 38 minutes, but in fact, it takes 119 minutes to see meaningful action in terms of pain scores dropping. So I made the mistake of giving it as a rescue medicine in second stage recovery, which did work. But boy, they got a lot of opioids, in the first stage recovery, and I use almost all general. So by giving it preoperatively, we're seeing right now, I've got a student working on this. It looks like it's going to be around 40% lower intra-op opioid necessary. And then in the first stage recovery, it looks like around 75% less opioid given, and sometimes none. I mean, these patients look like spinal patients. It's crazy. So, if those of you who don't know, it's a NaV1.8 receptor. It blocks specifically peripheral nerves at the synapse, the junction between the peripheral nerve and the spinal cord. No opioid effects, no nausea, no constipation, no vomiting. You have to stay away from grapefruit juice and antifungals. And um, so far, so good. I'm just hoping that there's not going to be some, 6 months from now that, there's some major issue. But so far, it's been a total game changer.
John, in sports, ice
Yeah,
therapy, drugs. I mean, game ready. What are you doing?
all of the above, but we are very low or no opioid use also, and that was amazing. When I was a resident, it was 60 Lortab and 20 Restoril and 20 Phenergan to every knee scope, and you sit there and go, golly, I can't believe what we were taught to do, and now essentially for multi-ligament knees they get narcotics, and for cartilage restoration, osteotomies, but we're even then it's 10 pills or 15, and we again, I think one of the things that changed my mind in the game, or helped me convince patients, was there was another lead article in JBJS. I don't know, maybe 2021, January, something like that, in that time frame. And there was a shoulder study, and it was the number one predictor of post-operative pain is a preoperative declaration that they had a high pain tolerance to their surgeon. And so you go, golly, well then this whole pain thing is clearly, it can be managed, right? It's not always the same. It's the body's perception of a noxious stimulus. So if you can change that perception in some way, then you can alter the pain profiles. Being in Austin, the whole keep Austin weird thing. We've got some folks who are interested in alternative actions as well that are non Western medicine historically, but we partner with, and from a disclosure perspective, OLS has a royalty investment with Corganics. They are a CBD company that gives medical grade CBD. You can only get it through a doctor's office as opposed to going down to the local smoke shop. And they come in creams and pills. And I have partners that use that as their postoperative pain routine in the absence of narcotics, and have had a lot of success with that too. And so when somebody asks about things like that, we have a company to send them to and a QR code to have them scan and go for. And certainly if somebody buys into that, then that's for it. We also get a lot of the natural stuff, because everybody in Austin goes and sees their chiropractor and Reiki provider and acupuncturist before they come to me for their bucket handle meniscus tear, and so we do a lot of turmeric and things like that people ask about, and so there's some supplements. In fact, Mend has a product like that too, but there are others out there also that people ask about too. So I think that's some of the non-traditional stuff we see a lot of, just based on where we live.
That's great stuff. Andrew, I'll get to you in a second. I just want to punch in one thing. One of the I feel one of the great litmus tests of any innovation is, if it came out first, would you ever do the other thing you were doing, irrespective of price or anything else? If that came out first. And a lot of these innovations we talked about tonight, like for example, the pods. If we were using pods, would we ever, if someone came up and said, "Hey, I have a new way to do it. Let's wrap a bunch of trays 400 times," and you'd never do it, right? So why, I always wonder, why is the sell so hard when you know the innovation is good? And sometimes price is a barrier, and we know that. I don't have to speak to the managing partner for that one. But these innovations are all fascinating because, if they came out first, we wouldn't be thinking of transforming to something else. Andrew, you were going to say something?
Just one other thing, I would say that extended length TXA has been a game changer. In addition to some of the other things, again, it's cheap. Even Paul Lombardi his team could afford it. Uh, um, it and we've got an article coming out, Joey here, hopefully any day now, showing that, we had like 947 or something like that consecutive hips and knees, and we had a total of 5 DVTs. So a lot of people are worried, oh, well, if you're going to give extended TXA, you're going to get DVTs. And yes, we had 5, but when you look at that, that's overall 0.47%. And they're all knees, interestingly, 2 proximal, 2 popliteal, 1 distal, if I recall. No PEs, but
One of my
I,
frustrations with TXA has been the anesthesia myths that come out about DVTs and can't give it to someone who's colorblind, who has stents. There's absolutely no data, reliable data, that suggests that TXA causes any of these things. But yet we're constantly being hamstrung by anesthesia to not use IV. Oh, he could use a topical. Well, I mean, it's been a consistent source of frustration.
there's a good article. It's like 30,000 patients, or maybe even bigger, that shows even high risk patients, MI, stroke, they overall do better with TXA versus without. So I had the same pushback from my anesthesia provider, and I just handed her the paper and said, get back to me when you have a come back to this.
Yeah, our group universally uses it amongst our joints providers.
That's great. So I'm going to go around as Nichols has echoed. This is the fastest hour in orthopedics. I know Paul could have gotten 3 joints done by now. Next time I see those balloons, I want to see 1,003. All right. We'll go around the room. I want some summary comments. Let's start with Andrew. Some summary comments about perioperative technologies, where we stand, what the future looks like, where you think the great hope is.
2 things. One, I'd like to just, I mentioned it maybe before we started, that maybe during the call, we've got the ViewMedi, I think is great. Like, I just started doing Subvastis, everyone's talking about it, and I can go to ViewMedi and I can look up anything at this point. And I'm really must say that as a technology that has really, just like YouTube, how do I fix this sync problem I have? I can YouTube it, right? It's been really, I think, a game changer in the last decade. And so I would say that is number one. Number two, I'm excited. Next week I'll be meeting with LA Therapeutics. They've got this bupivacaine wafer that's, man, it had great data in Australia, but then the FDA wanted to start it, wanted it redone in the United States. So it's going to be a 14-day intraoperative wafer that will slowly elute along that, anesthetic. I think that's going to be a game changer. The biggest thing we all need to remember is that as we start controlling the pain better with this NAV 1.8 and all these other things, pain is protective. And what happens when you have a neuropathic joint? It falls apart. So we really need to be very careful that when we start using these new meds and we start seeing side effects we don't want to see, like, again, if you've got this wafer and you walk all over the place, you're gonna have a big swollen knee, and now the manipulation rate, quadruples. You're gonna blame the way that the wafer disintegrates, rather than the fact that you didn't account for the fact the patient's gonna do dumb things. So I'm looking forward to that product. I'm hoping to see some data here next week.
All right, John, you want to give us your thoughts on this big topic?
Yeah, I think for me, the future looks bright from a intraoperative osteochondral autograft type world. I think we're not far away. In fact, we're very, very close to taking some adipose cells and being able to reproduce 3-dimensional autografts that can be used for joint issues, and hopefully decrease Dr. Lombardi and Dr. Wickline's work down the road from a joint replacement perspective. But that's really exciting. We're partnering with a company that may have some technology that I think will work down the road for that. For us, I think for my joints partners, that when you do get an infection, these things are terrible, and so the ability to disrupt biofilm down the road will be really important. I think the focusing on the holistic aspect. We always talk about patient-reported outcomes, and how does that, what outcomes matter, and is it pain, is it range of motion, is it function, is it the surgeon's preference, the patient's preference? We get graded on these things. but at the holistic approach to having the patient engaged in their recovery, the nutrition aspect, the ability to communicate remotely. AI is going to play a role in all of that also in evaluation. So there's a lot of technology that's going to improve our outcomes. I actually don't. I'm not of the mindset that thinks the surgeon's going to get replaced by a robot anytime soon. Our radiologist might, but I don't think we will.
All right, Paul, you want to bring us home? And then I have one more comment for the group.
Sure. Yeah, I think that, John gives me a great segue to talk about, I think, where AI is going to take us in the future. I think that we're going to be able to, as a hip and knee replacement surgeon, I think that AI is going to take all of my demographic data, types of patients I'm operating on, and I think I think Russell Bodden was on the call tonight, and I think all the patients for a hip replacement are going to have this pelvic, spinal pelvic relationship studies, and we're going to be able to determine, very accurately, I think, who's going to dislocate, who isn't, we're pretty close, but I think we're going to really zone in with AI in hip replacement. And I think in knee replacement, the debate about whether we're going to use kinematic or mechanical alignment, I think AI is going to be able to individually dictate to each patient where our components need to be situated for optimal results. I think that's what's coming down the line.
Excellent. So I'm going to just give a shameless plug to a topic session coming up at the end of August, the Red Hat protest, because we love our reps. Joey's going to be doing this on August 27th. You have more than enough time to plan. Michael Redler is going to be the moderator, although I don't think I told Michael yet, but we'll see. So that's my shameless plug for 1 month from now. I think this was a great session. I have hats off to the panelists, Paul, John, Andrew. I really appreciate it. I'm a little disappointed I wasn't one of Paul's residents, but I guess I was.
I was the second one, so I didn't get a chance to talk earlier. But
oh my God, Wade, good to see you, bud.
Yeah.
All right, we've gone full circle here. Excellent.
Yes, we'll bring you coffee and donuts. Yes.
Thank you.
Okay. August 27th, Red Hat protest. Be there. We're going to break the bank in terms of participants. And yes, you did tell me.
Oh, I did tell you. Good. I'm getting older. I don't remember everything.
So it's good when you find out live on the show, isn't it, Dr. Redler?
No, I actually knew, and we're going to break the banks, and it's for a great cause and for such an important part of the surgical team.
You bet. Right. Awesome. So with that, I'm going to say thank you and good night to everyone.